في حد هنا من الضيوف ما بيتكلمش عربي عشان ما نتكلمش عربي خالص؟ تمام تمام. بسم الله الرحمن الرحيم. بنرحب بيكم في اليوم الثاني من المؤتمر الناجح دائما، مؤتمر قسم الأشعة التشخيصية. هما بقى اسمهم كبير قوي الحقيقة، فأنا مش عارف اقول بقية الاسم ومش عارف وفي حاجة جزيئية في الآخر كده مش فاكرها. وصف تفصيلي يعني. تمام. بس احنا كده بقى نسمي اسم جراحة العظام والعمود الفقري والعضلات عشان ما حدش يتلخبط يعني. شرف كبير ليا جدا جدا ان انا اشارك في رئاسة الجلسة. انا عبد الفتاح سعود، استاذ جراحة العظام والعمود الفقري والرئيس السابق للجمعية العالمية لجراحة العمود الفقري. ووظيفة اخرانية كده يعني غير دائمة، الناس بتعدي عليها كده وتمشي. انا نائب رئيس جامعة عين شمس لشؤون التعليم والطلاب. طبعا يعني شرف كبير ليا جدا جدا ان انا اكون موجود كواحد من اللي هيديروا هذه الجلسه. بتشرفنا طبعا الاستاذ الدكتوره منال التهامي، رئيس قسم الاشعه في طب الزقازيق. وطبعا طب الزقازيق متميزه جدا جدا في كل حاجه، لكن انا عارف ان اسم الاشعه بالذات قوي جدا 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 في طب الزقازيق. طبعا استاذنا الفاضل اللي تواضعا قاعد تحت، احنا ما يصحش نقعد فوق حضرتك موجود يعني، فشرف كبير جدا جدا لينا الوجود مع حضرتك دكتور محمد. طبعا بيشرفنا جدا جدا طبعا استاذ دكتور حسام صقر، وهيمتعنا بقى باول محاضره احنا الاثنين هايلي انترستد فيها. هيكلمنا عن الدايناميك MRI اوف ذا سباين. اتفضل يا دكتور حسام.
Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizer committee of this valuable conference for inviting me to share in this, and all the attendees for their attendance, and I hope this will be beneficial for them. I will talk about dynamic MRI of the spine. The spine is a complex biomechanical system with a double supportive and protective function. It can adapt to various stresses to which it is subjected by posture or daily activities, different daily activities such as work, sports, and even dancing, and someone all needs the spine and in spine and a good health to support all these activities. We can divide can define the functional spine unit, to which we will talk about by functional spine unit is composed of the intervertebral disc and the vertebral end plates of the two adjacent vertebrae and the facet joint. 70% of the workload is subjected to the anterior part of this functional spine unit, which includes the intervertebral disc and the vertebral end plates of the adjacent vertebrae, while only 30% is transferred through the facet joint or the posterior aspect of the functional spine unit. Degenerative disease of the spine is a definition that includes a wide spectrum of degenerative abnormalities that involves bone structures and the intervertebral discs. Various aspects of spine degeneration are strictly linked because they have common pathogenic factors. To simplify, we various systems for classification of the degenerative changes. The most simple of one of them is the ABC degenerative changes system. 8 changes that include the process of degeneration starts within the nucleus pulposus and is limited to it, while in B changes the abnormalities extend to the disc, so to the annulus fibrosus of the disc and the end plates and bone marrow of the adjacent vertebral bodies. The C changes which stand for advanced degeneration involves the distant structures leading to facet joint arthropathies, ligaments and flava thickening, and spinal canal stenosis. Spinal instability can be defined as the loss of the ability of the spine under physiological laws to maintain its normal alignment. Degenerative spondylolisthesis is defined as the excessive translation of one vertebra over another due to degenerative changes of the supporting structures. Degenerative spondylolisthesis is divided into static spondylolisthesis, which occurs during rest and during all activities, and dynamic spondylolysis, which is demonstrated inability on flexion or extension position only, instability on flexion on the extension positions only, not on rest. Spinal magnetic resonance imaging is the imaging modality of choice in assessing pathological changes at the spinal cord, vertebrae, discs, ligaments, and facet joints. As we are all know that MRI have excellent resolution for both bony structures and soft tissues, can give us many information and details about all these structures. Dynamic MRI of the spine has been increasingly used to demonstrate spinal cord compression and spinal instability. Dynamic spine MRI shows more significant findings in comparison with the static spine MRI. Recent studies concluded that the evaluation of cervical spondylotic myelopathy was improved in about 72% of patients with extension MRI in comparison with neutral MRI only. Dynamic cervical spine MRI is an important investigation before deciding surgical treatment in patients with cervical myelopathy. Many classification systems for degenerative spine diseases are used based on MRI. The most accepted one of them is Moll scoring system, which proposed a classification system for degenerative diseases of the cervical spine based on MRI findings into 4 stages. 0 stage is a normal spine, 1 partial obliteration of the anterior or posterior subarachnoid space, stage 2 complete obliteration of subarachnoid space, and stage 3 cord compression and or displacement. The technique of dynamic MRI of the spine, it depends on putting the patient into either flexion or extension position, either for the cervical spine or lumbar spine, using cushions, and to maintain this position, as we all know that movement will produce artifacts and decrease the resolution of the image. So we should put the patient in a comfortable position in order to maintain its position with his position without movement during the exam time. The degree of extension of cervical spine is measured as the acute angle between a line drawn parallel to the posterior cortex of the C2 vertebral body and the line parallel to the posterior cortex of C7 vertebral body. This is important to determine if the flexion we put the patient into this position is enough or not. Some patients have rigidity and difficult to obtain flexion. After we doing this dynamic MRI, either flexion, extension, either for the cervical spine or lumbar spine, what we will look for? What is the parameters we use to interpret the images and interpret the study? The morphometric parameters evaluation and T2 weighted MRI sequence of the neutral flexion and extension position for the cervical spine. 4 parameters are the diameter of the vertebral canal, the diameter of the spinal cord, the anterior length of the spinal cord, and the posterior length of the spinal cord. This is how we measure the the diameter of the vertebral canal is the shortest distance between the center of the posterior edge of the intervertebral disc of each segment and the anterior edge of the rumentum flava posteriorly, while the diameter of the spinal cord is the shortest distance between the anterior and posterior edges of the spinal cord. We should compare these measures between neutral, flexion, and extension images. As regarding the anterior and posterior lengths of the spinal cord, we measure them between 2 limits. The limit, the upper one is the straight line crossing the spinal cord as the upper edge of the anterior posterior arches of C1, and the lower limit is a straight line passing along the lower terminal plate of C7. As regarding the lumbosacral spine and the morphometric parameters, we will interpret in dynamic spine MRI of the lumbosacral vertebrae. The lumbosacral angle is defined as the anterior open angle intercepted by the 2 tangential lines of the anterior walls of L5 and S1 vertebrae. The normal range is between 120 to 180 degrees. Increased angle corresponds to vertical tilting of the sacrum, which biomechanically produce an increased load on the anterior column and accelerate the degeneration of L5S1 disc, while decreased angle is associated with citrum horizontalization, which consequently creates an amplified load on the posterior element, meaning the facet joints, leading to their degeneration. Lordosis angle is the superior open angle intercepted between the two perpendicular lines to the tangential lines of the superior end plate of L5 and inferior end plate of L1 and the inferior end plate of L5. This angle has a normal value of about 30 to 50. The decrease in lordotic angle reflects the compensation by muscle contraction. This is how we measure the lordotic angle. After all that, I will give example to show what is the importance, what is the added value of adding these sequences. It takes time, so it is not a long time to obtain these sequences, but every sequence will add it to the exam should have a beneficial role in diagnosis. So we'll show in these examples. Case 1, 49 years old female with bilateral lower limb stiffness. This is the sagittal T2 in neutral position and in extension position. We do mole classification or scoring system for each intervertebral disc, level of the intervertebral disc in the two positions, either the neutral, static neutral, or dynamic extension. Nearly all levels are changing. The scoring changes between the neutral and extension position. The most significant one of them is, and we will look for, is C3-4 level. It is completely normal in the neutral static MRI, while in extension position, a significant compromise to the disc, to the spinal cord with protrusion of the disc and deformed spinal cord, and will explain the abnormal signal within the spinal cord opposite this segment. A big difference is noticed, and this is true. This is position of the spine of the patient affects the load on the disc and will lead to more apparent disc bulge and effect on the spinal cord. Case 2, 55 years old male with neck pain and left brachialgia. This is also the comparison between the mole classification or scoring system between the static and dynamic positions. Also nearly all the levels changing, starting from C3-4 to C6-7 levels. We look for C6-7 level. Here in static, there still just the disc bulge is just touching the spinal cord, while in this extension position it is compromised by the disc bulge. And this is the axial cuts and more towards the left side, so it's explaining the patient complaint of left brachialgia. Case 3, 45 years old male with neck pain and right brachialgia as well as left sciatica. This is the cervical MRI static neutral flexion and extension. This is the mole classification. There is no big difference between neutral and extension images. So we move to other parameters, the diameter of the vertebral column and diameter of the spinal cord at the C6-7 level. We notice a big difference. In the neutral position, the diameter of the cord is about 2.5 millimeter, while in extension position, it is only 1.9 millimeter. While in flexion, it is much larger, 5.3 millimeters. Big difference between the extension position and the neutral and flexion ones. Also, the diameter of the vertebral canal, but the change is smaller, only 4.8 in the neutral position, while 4.5 in extension position. And this is the axial image. Case 4, 36 years old male with history of falling from height 1 year ago, underwent L4 and L5 spinal fixation and spinal laminectomies. Now he is complaining of neck pain and bilateral brachialgia, also low back pain and bilateral sciatica, more on the left side. This is the cervical spine, neutral and extension position. There is no big difference between all levels. And this is the lumbosacral MRI, neutral flexion and extension positions. The angles, the lordotic angle is, lumbosacral angle is normal, while the lordotic angle is decreased, indicating muscle spasm. There is no difference between all these. But guided by the clinical condition of the patient, he is left sciatica, he complains of this sciatica. So we should not look only for the midline image. We should look for the neural exit foramina, either right or left, guided by the patient general condition, clinical condition. This is the left neural exit foramina in both in neutral flexion and extension position. We see that it is more affected in the flexion position. We can magnify. This is in flexion position. The neural exit foramen is narrower than in neutral position. Explaining the patient condition of our patient complaint of left sciatica. Case 5, 76 years old male with left sciatica. Also, the lumbosacral angle is normal. The lordotic angle is decreased, indicating muscle spasm. But in the midline images, there is no big difference between different positions. Also, in the right, and assessing the right neural exit foramen, there is no big difference between different flexion and extension and neutral position. Yet in the left neural exit foramen, this is more affected in extension, and this is what we found in the neural exit foramen is a little bit more compromised in the extension position. Case 6, 56 years old female with left sciatica and left foot drop, history of lumbar disc surgery and fixation 9 months ago. Also, this is midline images, decreased lumbosacral angle due to the muscle spasm, normal decreased lordotic angle and normal lumbosacral angle. The L5 S1 disc protrusion is more apparent in extension position. This is in the neutral, this is in the flexion, and this is extension. It is more caudally migrated in extension position. And if we measure the protruded distance, it is much more in extension position. It is about 8 millimeter, while only 4 in neutral and flexion positions. And the compromise to the left neural exit foramina is more in extension position. The take-home message: spondylodegenerative changes of the spine and the spinal instability are common medical conditions that affect the quality of life and productivity of the patients. MRI is the imaging modality of choice in patients with clinically suspected spinal degenerative changes and/or instability. Static MRI gives important data as regarding the intervertebral discs, facet joints, ligamenta flava, vertebral marrow, yet it can underestimate the pathological changes. Dynamic MRI can detect pathologies missed by static MRI, explaining the clinical finding. Thank you.